So let's have a look at concordance. What is the size of the problem? Well, firstly, we're going to be looking at the size of the problem and what it means in terms of patient outcomes. In the last module, we examined the fundamental differences between those terms. Compliance, the very doctor-centered term; adherence, the buzz term of the noughties when we talked about patients engaging; and then concordance, the broader discussion where the patient and doctor are equal partners at every stage. Now, we're going to be talking about what that means. The simple fact of the matter is that regardless of how the patient's engaged, if they are not engaged, if they do not buy in to the agreed management plan, they will not continue with their medication, they will not continue with lifestyle changes. And that, the evidence shows us very clearly, results in poorer outcomes for patients, not to mention frustration for us as their healthcare professionals. So, what do we have here? An example from diabetes. How many hours are there in a year? 8,760. That's an awful lot of hours. I decided not to add the noughts on for minutes. Of those, if the patient is working full-time, how many hours are they working in a year? On average, 1,880. And of those, 3, if they're lucky, are spent with all their healthcare professionals put together. Doctors, nurses, pharmacists, dietitian, podiatrist. That's an average, but you get the picture. We all know about the 10 minutes for the patient, and it hasn't changed so very much. So we are looking at a patient who spends 3 hours with us put together, and then is expected to spend 8,757 hours doing what was agreed in those 3 hours there. So let's think about why patients might not buy in. We all assume that side effects are a major predictor of concordance, and of course we are right, but they are by no means the only predictor of concordance. Let's use, as an example of this, antihypertensive medication. Really, it's only in the last 3 decades or so that we've genuinely embraced preventive medicine, and that we've had so many conditions, dyslipidemia, type 2 diabetes at its early stages, hypertension, where the patient comes in feeling absolutely fine. We give them a diagnosis, in other words, a disease label. We turn them from people into patients, and we tell them that we need them to take medication for the rest of their lives when they feel fine at the moment, which is, in the short term at least, likely to make them feel worse. So if we think about what the medications are that we have, and we think about persistence with medication at just 1 year after a prescription for antihypertensive medicine, if we take at the start a drug which has placebo-like side effects, that does not mean no side effects, as we all know how many patients in placebo-controlled trials experience, quote, side effects, and indeed how many patients have to come out of trials because the side effects from placebo were so severe. But if we think about it, the best tolerated antihypertensives without doubt are the angiotensin receptor blockers, the ARBs or the A2As as they're sometimes called. In 1 year, 36% of patients had stopped those medications, which could save their lives or prevent them from having a myocardial infarction or a stroke. When you get onto drugs which have got side effects, ACE inhibitors, of course, on the whole, well tolerated, but they do cause dry cough, probably in about 1 in 10 women and 1 in 20 men. They're 58%. So again, 42% of patients had stopped those medications by 1 year. If we then move on to drugs which have more side effects, the calcium channel blockers with their flushing, particularly with their ankle swelling, exactly half of patients had stopped them. And if we get onto the drugs which have really high levels of side effects, the old-fashioned drugs, the thiazide diuretics, the beta blockers, with their gout, dizziness, erectile dysfunction, shortness of breath, tiredness, we're seeing that the majority, 72% of patients who were started on a thiazide diuretic have stopped taking it within a year, leaving them to all intents and purposes, unprotected against the risks from hypertension. And actually, you might think of that as being a short-term problem, but in fact, again, the evidence is that while the vast majority of drop-off from medication comes in the first year, if we look at those same drugs again, the A2As, the angiotensin receptor blockers, the ACE inhibitors, the calcium channel blockers, the beta blockers, the thiazide diuretics, there is a significant drop here, a drop of 7% of patients who were taking it at the end of 1 year, but who within 4 years have stopped taking the medication, and this is against medical advice. So it's not just about side effects, although there's no doubt that side effects do play a major part. What else makes a difference then? Well, there's no question that simplicity helps. A tablet that you take once a day that you can put with your toothbrush, doesn't matter what time of day you take it, doesn't matter if you're out late, don't need to take it before meals, after meals, whenever, slips down easily. Yeah, that's going to be a drug which patients are more likely to take reliably. If you go to, say, bisphosphonates, where the patient has to sit up straight, drink it with a full glass of water, be upright for at least half an hour after they take it, no food for up to 2 hours afterwards, of course, there are going to be problems for some patients, especially patients with osteoporosis who may well be elderly and frail. With other medications, do they interact with each other? Do you have to take them at separate times? Do you have to take the medication with or without food? Are you taking one set of tablets which is taken 3 times a day, morning, afternoon, nighttime, and another set which is taken 4 times a day, where you have to space it out by 6 hours rather than 8 hours? It all gets terribly confusing. So let's look at what happens when we do get patients engaged. This is one example. This is the US Diabetes Prevention Program. Now, this was an extraordinary study. It's not a placebo-controlled trial. If you look at the study, what they did here was they took 3 groups of patients, all with pre-diabetes or metabolic syndrome, as they probably called it then, and they randomized them to one of 3 groups. What we're seeing here is that one group was given placebo, the other group was given the active drug. So far, so good in terms of making it a double-blind placebo-controlled trial. However, the third group was randomized to intensive lifestyle. It is very difficult to randomize somebody either to standard advice, in other words, stop eating all the pies, take this tablet once a day, come back and see me in 3 months, or to try and get them to do 4 hours of exercise a week without them knowing which study they're in or which side of the study they're in. But what we saw was that the differences were huge. Compared to placebo, over the course of the study, there was a 31% reduction in progression to type 2 diabetes among those patients who were randomized to metformin. But far more extraordinary, without a drug in sight, was the improvement that was gained by patients who were randomized to intensive lifestyle. There we saw a 58% reduction in progression to type 2 diabetes. But there are some lessons which are not quite as positive from this. The first is it was pretty difficult in all the studies like this to recruit, because actually, and this is a personal statement but backed up by 28 years as a GP, patients would much rather pop a tablet in than give something up, whether that something is their favorite pie or their free time to go and do some exercise. That's the negative side. On the plus side, we can make an enormous difference by early changes. These people hadn't even developed type 2 diabetes yet. So we can make a huge difference to somebody's likelihood of developing a condition, or indeed of developing complications of the condition or complications from treatment. So this is the US study here, but the Finnish study extraordinarily showed an identical reduction of 58% in progression to type 2 diabetes with lifestyle. And if we just look at how they did that, they weren't being that extreme. They were trying to get their body mass index down to below 25, regardless of their ethnicity. We didn't know as much about the impact of being of South Asian origin on body mass index back in those days. Or they were going to get them to reduce it by 5%, whichever was the less. So they weren't trying to get someone with a BMI of 35 down to below 25. They were doing what in those days was considered a good heart healthy diet. I know there's lots of discussion about the relative roles of carbohydrates and fat, but in these days the recommendation was that for total fat you should have less than 30% of your total calories as fat, and that your saturated fat should make up less than 30% of your total fat intake. Interestingly, they were trying to get their fibre, both their soluble and their insoluble fibre, up significantly, and importantly, they were trying to get them to do exercise for at least 4 hours a week. In this study, they had one initial session with a dietitian or a nutritionist, and in the first year they had 2 monthly sessions, so 7 sessions over the course of the year, 3 monthly thereafter. They were given personalised exercise on increasing their physical activity, and really importantly, they had motivational interviewing in order to try and get them to identify their own triggers or their own reasons for wanting to change. We will talk more about that later, because this is a very important concept where concordance is concerned. So, what did they do? Over the course of 2 years, actually they didn't end up weighing that much less. They only weighed 3.5 kilograms less over the course of 2 years. In fact, a difference of even less than that. It was only a difference of 2.7 kilograms between the placebo group and the lifestyle group, but they did have a 58% reduction in their progression to type 2 diabetes. This is what happened with the weight, and again, people are human, so perhaps we shouldn't be surprised. We started off with a great bang, and patients dropped a lot of weight in the early months, and then that gradually tailed up. And I think more importantly, if we look over here, what we're seeing is that by 10 years after randomization, these patients almost weighed the same, whether they came from the metformin, the placebo, or the intensive lifestyle arm. But really importantly, the incidence of type 2 diabetes, of course, widened most in the early stages, but that improvement persisted. And by 10 years after randomization, those patients in the intensive lifestyle arm were still 34% less likely to have developed type 2 diabetes, and those in the metformin arm 18% less likely to have been diagnosed with type 2 diabetes than those in the placebo arm. So what we're seeing is that changes in the early stages can make a huge difference. This is what we refer to as the legacy effect. What have we done since then? Well, what we've seen is the majority of these studies since then have looked at metformin, of course, in the DPP, but we've also looked at acarbose, not a drug that I have to say I've ever had any success in getting my patients to take, especially if they live in a household with anyone else who has a sense of smell, or hearing for that matter. But we've also got the Zendo study where they were looking at orlistat. And what we saw there was that if you have an added bonus benefit, and in this case, of course, with orlistat, the added bonus benefit was weight loss, that actually you do get significant improvements. So significant buy-in from patients if they have an added bonus benefit. Let's hang on to that. So the UK PDS, we think about the legacy effect, it comes from there. What we saw there was that patients who were treated with intensive blood glucose control, we found that in the early stages, that reduction in microvascular events did not quite extend to macrovascular, but 10 years later, the reduction was the same. We're seeing the same sort of concept in the diabetes prevention program. Intensive lifestyle in the early stages will extend in the longer term and protect the patient, even if not to the same extent, from developing type 2 diabetes. But we also see that people are human. We genuinely can make a difference, especially by engaging and getting patients buy-in at an early stage in long-term complications. But we need to bear in mind that the patient does need constant motivation.